Echocardiography plays a central role in the evaluation of patients with known or suspected coronary artery disease. And Luc Pierrat will present how to perform exercise echocardiography in a patient with silent myocardial infarction. He will show the presence of inducible ischemia related to significant coronary artery disease. And on a second exam performed a couple of months later after CABG, he will highlight the usefulness of exercise echocardiography to identify the underlying mechanism of dyspnea by detecting the presence of dynamic mitral regurgitation and pulmonary hypertension.
Well, first a few words regarding our patient. He comes for cardiac examination because he has several risk factors of coronary artery disease. A past history of smoking. He stopped smoking 5 years ago. He is treated by simvastatin for hypercholesterolemia. Still has an LDL cholesterol between 120 and 140 milligram per deciliter. He is completely asymptomatic. His clinical examination shows increased systolic blood pressure of 170 millimeter of mercury. He has no cardiac murmur. The electrocardiogram shows incomplete right bundle branch block and left axis deviation. There is no abnormal Q waves. So we will do a resting echocardiogram first. And well, we begin as usually by the parasternal window showing the parasternal long axis view. And second, this is the short axis view at the level of the papillary muscle. It shows normal contraction, normal thickening. Then we go to the apical window to obtain the four-chamber view. Well, this looks a little strange at the level of the post-receptal wall in the basal part. Looks non-kinetic. So we move counterclockwise the probe to obtain the two-chamber view. And this is a surprising finding. You see that there is an infarct at the basal one half of the inferior wall, good contraction of the anterior wall, and aneurysm, or at least infarct expansion. So the last is another clockwise rotation for the apical long axis view, which looks rather normal in contraction, in endocardial motion, and myocardial thickening. Well, because of this distortion, it's possible that the patient has some mitral regurgitation. So we look to the color flow. There is indeed a mitral regurgitant jet from the left ventricle to the left atrium, which should not be quantified according to the area of regurgitant flow in the left atrium because of several technical and physical factors. We can try to obtain the conversions region. While it's rather difficult, if there are a pisa, it's certainly very small. It's interesting also to look at the regurgitant jet and the pisa radius with color M mode to ensure that the pisa radius is similar throughout systole. Usually we have a higher pisa radius at the beginning, at the onset, and the late systole in secondary mitral regurgitation. You have seen that the mitral valve apparatus looks normal, so it is not a primary MR due to mitral valve disease, but rather a secondary MR due to the infarction. So we decide to do an exercise echo because if the patient is capable of exercising, he has no significant lung disease or vascular disease, it is better to use exercise rather than a pharmacological test because it will provide information on the evolution of blood pressure, the significance of eventual ST segment depression is well known with exercise echo. And so the problem is how, well, we will take the same images as at rest, but when should we begin the low charge exercise? I think that there are two different conditions. If there are subabnormal motion and thickening at rest, let's say hypokinesis rather than in this patient dyskinesis and infarct expansion, it's probably more interesting to take images rather immediately at the beginning of exercise when heart rate increases and when it's evident that there is some contractile reserve, to potentially identify a biphasic response at peak of exercise. So here we have a heart rate of 86, and we will take the long axis view, the short axis view, and again the apical 4-chamber, the 2-chamber view. That's clear that there is some improvement in myocardial thickening of the anterior wall. Of course, no change in the inferior wall, which represents a transmural complete myocardial infarction. And this is the apical long axis view. Then the patient should exercise until exhaustion or until at least the target heart rate is reached, or of course if he develops angina or significant ST segment depression or arrhythmias. So we go to peak exercise. The heart rate is 141, so it is above the target heart rate. And again, the short axis view. This is a daily life examination, so the quality of imaging is not perfect. Perhaps that we could have decided to improve the endocardial detection by opacification of the left ventricle, but we do not do that really at the end of exercise. So we take now the recovery. Apical long axis view, short axis, and the same for chamber view, 2-chamber view, and apical long axis. So one important point is to look at the images quad screen. So we will see at rest on the upper left side, at low charge, at peak exercise and during the recovery. Well, there is clearly a training learning curve to analyze qualitatively these images. It looks like at least the anteroseptal wall is hypokinetic at peak exercise as compared with low charge. So let's look to the short axis view. So again, the myocardial thickening is lower at the level of the septum and perhaps the anterior wall, which is not very well seen in this view. We take the 4-chamber view. So again, there is clearly abnormal thickening at the apical region of the septum as compared with rest and low charge. We continue with the apical 2-chamber view. Well, clearly there is no improvement at the level of the transmural infarct, and it seems that the anterior wall is less contractile at peak exercise as compared with low charge of exercise. And, well, the last is the apical long axis view, which may be interesting. Well, it's less obvious that there is a real problem at the level of the septum, although we can sometimes decrease the rate of images to look at possible tardokinesis or post-systolic shortening. It is difficult to assess the posterolateral wall, but I think that in this example, I suspect that there is subabnormality of the posterolateral wall as well. So perhaps that we could look at the results of two-dimensional strain. So with two-dimensional strain, we can have a bullseye which nicely shows that there is an area of no strain, no deformation in the territory of the transmural infarction. We do not really need two-dimensional strain to identify that the inferior wall and basal perceptual wall are dyskinetic and without thickening, without deformation. The other areas looks quite normal in the two other territories. Of course, we have looked to the electrocardiogram. The patient had no chest pain, no arrhythmia. He had a small increase in systolic blood pressure from 140 to 150, but he has a 2 millimeter down-sloping ST segment depression in inferior and lateral leads, and also something which could give some information. He has a ST depression in the lead AVR, which has been validated as a possible sign of left main artery stenosis. So let's look now to the bullseye of deformation, longitudinal deformation at peak exercise, where we see, if we compare it with rest here, there is clearly abnormal strain, abnormal deformation in a large territory, perhaps with the exception of the apex, which may be strange, but clearly at the level of the anterior wall, lateral wall, posterior wall, suggesting that although it was not really evident from grayscale images and the qualitative interpretation, there are signs of multivessel coronary artery disease in these patients who had a previous completely silent inferior infarction. And so, of course, there is no doubt that coronary arteriography is required. And so I give you the result of coronary arteriography. There was indeed a 60% diameter stenosis of the left main artery. There was 50 to 60% stenosis of the mid-LAD, and there was 60% stenosis of the marginal branch and the distal circumflex artery, and of course a complete occlusion, thrombotic occlusion, old probably, of the right coronary artery. So even if the patient is asymptomatic, the extent of induced ischemia is a clear indication for revascularization, which was not possible percutaneously, so it was decided to submit the patients to surgical revascularization. He underwent bypass grafting with the use of the right coronary artery as graft to the two marginal branches. The left was used to do a graft for the LAD and a diagonal branch, and there was no grafting of the right coronary artery, which were completely occluded, with some distal opacification by collateral flow, but was in a territory of transmural infarction with no possible functional recovery. So in summary, asymptomatic patients with some risk factors comes for clinical examination, no Q waves, but the evidence of a large transmural with infarct expansion in the territory of the right coronary artery, normal thickening of the other walls, some mild secondary mitral regurgitation, positive exercise test on electrocardiography, no chest pain, no angina, but the evidence more striking, I think, by the two-dimensional strain and the bull's eye presentation in the other coronary territories. Well, this is the same patient 10 months after his successful surgical revascularization. Of course, he has no angina. He had no angina before, no during the exercise test. So he quite well with no chest pain, but he mentions the development of significant dyspnea at exercise, perhaps that he does more exercise than previously. And so we decided to redo an exercise stress echo to assess whether there are possible myocardial ischemia. So this is the results of his exercise test. You see the parasternal long axis view at rest, at low level of exercise, peak exercise and recovery. And on this view there is no evidence of ischemia. We show now the short axis view, again at the level of the papillary muscle. There is no evidence of ischemia. This is the apical four-chamber view with clearly no evidence again of myocardial ischemia. And of course, no functional recovery of the inferior wall. This is not really surprising, and no evidence of myocardial ischemia. So how could we explain the significant dyspnea of the patient? So we look to the mitral regurgitant jet, which looks quite similar, and again, not surprisingly, as compared with the previous before revascularization examination. So we look to the mitral valve. The mitral valve is, mitral leaflets are normal. There is some tenting of the leaflets with small motion of the posterior leaflet. And we try to quantify, even it remains relatively difficult. You see that there is some PISA where I have decreased the aliasing velocity to 32. And we have a PISA radius of 7 millimeter, 0.7 centimeter. Then we take, of course, the continuous wave recording of the regurgitant jet, and the machine shows the results. The effective regurgitant orifice area is only 0.1 centimeter square, so 10 millimeter square. The regurgitant volume is somewhat higher, 35 milliliter. So it is mild to moderate secondary mitral regurgitation. We look also whether there is some signs of significant mitral regurgitation with the measurement of the E wave, which is lower than 1 meters 0.4. We look to the tissue Doppler recording at the septal level, and the E to E prime ratio is high. So this is a possible explanation of his exercise dyspnea because of diastolic dysfunction. But during the exercise, on top of the grayscale and the different views, we put the color on. So clearly, even if we do not believe in regurgitant jet area to quantify mitral regurgitation, it's evident that there is an important increase in the severity of secondary MR during exercise in this patient. So we quantify it again by the PISA method. The PISA radius is larger, and the results not shown in this image was an effective regurgitant orifice area of 0.3 centimeter square, so a large increase as compared to rest, leading from mild to moderate MR at rest to severe MR at rest, which was accompanied by the development of significant pulmonary hypertension. And so if we look, there is nearly 4 meters per second, so the transtricuspid pressure gradient is approximately 50-55 millimeter of mercury. We have to add the right atrial pressure, which is indeed difficult to assess during exercise by the measurement of the inferior vena cava diameter. So usually we add 10 millimeter of mercury, and the patient has developed significant pulmonary hypertension with a systolic pulmonary arterial pressure estimated at approximately 60 millimeters of mercury. Interestingly, it's also important to look at the patient. And the patient developed significant dyspnea in relationship possibly with diastolic dysfunction, but more probably because of the increase in mitral regurgitation and the development of increased pulmonary pressure. It may be also interesting to do clinical examination at the beginning or at the end of a stress echocardiogram or another mode of echocardiography. At rest, the pulmonary auscultation was normal. At the end of exercise, with his dyspnea, we had the development of pulmonary rales, which clearly was in relationship with the severe dyspnea and with all the abnormalities that I have tried to show you. So in summary, 10 months after revascularization, there is no evidence of inducible ischemia, no ST segment depression on the electrocardiogram, a high increase in systolic blood pressure during exercise, but a dynamic secondary mitral regurgitation with a large increase in the effective regurgitant orifice, the development of pulmonary hypertension, and also the development of pulmonary rales at clinical examination.
So what are the key messages of these examinations? First, exercise echocardiography is useful to detect the presence and extent of myocardial ischemia in patients with coronary artery disease. Interpretation of the test is often made using semi-quantitative approach, but quantitative approach are also of interest. Finally, look not only at the function, but also at the valve and hemodynamics, and of course at the patient.